So today we'll talk about leg length deficiencies. Research says that they affect 70 to 90% of the population, although not all of them are significant. We know they can be anatomical from someone who has degeneration of a joint or maybe a prior fracture, but a lot of them are functional from somebody who has flexion of their hip or flexion of their knee, maybe dorsiflexion of their ankle, or they have a fallen arch of the foot. A lot of these are related to functional deficits. What's the best test to identify it? We have no idea. We're not the experts. But ALF took a look at 52 studies with a systematic review and meta-analysis and determined what is best. Unfortunately, the best tests are imaging, doing a plain film radiograph of the entire leg length and then measuring that on a PAC system would be the gold standard. An MRI does a really good job as well. CT scanogram is an option, but maybe not better than just the plain film radiograph. But for you and I, we're not often going to expose the patient to imaging or x-ray in order to determine a functional leg length inequality. So he gave us a couple of options for that are valid and reliable. Number one is using a tape measure, having the patient lie on their back, and we're going to measure from the ASIS down to the medial malleolus. So we hit the ASIS, come to the medial malleolus, and compare 2 or 3 readings on each side. There's a number of ways that we can do that. We can go to the lateral malleolus, we can go from the pubis to the medial malleolus, but really it seems like going from the ASIS to the medial malleolus would be the best route. The other way that we can do that is through a prone leg length check. This is one that we're probably most familiar with. The patient's lying down, hopefully on a table where they can relax their upper body as well. We're going to approximate their heels, bring them together, and take a look, is there a deficiency? We can also potentially quantify that deficiency with a millimeter ruler, putting it on the short leg and seeing which one, exactly how much shorter one leg is than the other. We could also do this from a standing leg length check. And surprisingly, ALF told us that this is fairly reproducible and reliable as well. We're going to stand behind the patient. Ideally, we'd have them walk 10 feet forward, come back, and then stop. And when they stop, we're going to put our hands on their hips, and we're going to measure from side to side to see which hip could be higher than the other. There's a way to quantify this, and this is through something called a palm. So this palm or palpation meter is something that can actually put a number on it, and it's a simple device. It's a caliper and an inclinometer with a little level ball in the middle. And so what we'll do is we'll measure with this, and then we can see which way does the ball drop on the level. Whichever side the level is dropping towards, we know that's the short leg. And again, we're probably going to do 2 or 3 measurements from side to side and average those 2 out. Now the best test is a combination of those. It's called the block test. So when we put our hands on the patient's hips, or in this case augment that by using a palm, we're going to say which side is low, and we'll say that Dr. Steele has a low right-sided leg, so his right leg, his right hip is dropping down. What we're going to do is then take a block, or in this case a heel wedge, or any other type of shim that you have that's measurable. We'll put it underneath the patient's heels. We'll probably have that patient take their shoes off. And then we're going to put this under the heel and remeasure and see at what point in time does the pelvis level back out. That allows us to detect the leg length inequality. It also allows us to quantify that leg length inequality. So in this case, we're going to slide this block underneath his right heel. I'll remeasure then 2 or 3 times and say, has it leveled out now? And whichever block that we use, we know that's the right one. I have a 3 millimeter, a 5 millimeter, and a 7 millimeter. You can combine those if you need more, but once we start getting up into that post 7, 8, 9 millimeter, then we have to think about building up the shoe itself. So ALF told us that the block test is the best test of all to identify that. Now, we then have to say, how are we going to address it? Well, first we're going to try to get rid of the functional deficits, and the biggest one of that is the functional deficit of potentially hip abductor weakness. That if we have a patient who has weak hip abductors, their legs come together, which causes hip flexion, causes knee flexion, both of which shorten a leg. It also causes internal rotation, which shortens the leg, dorsiflexion of the ankle, and hyperpronation of the foot. So we get rid of the functional deficits anywhere along that chain, whether it be hyperpronation, hip abductor weakness, sacroiliac joint dysfunction, and then we can consider how are we going to address the structural components.
It's sometimes a chicken and egg story. So when you have someone that has hip flexor hypertonicity or a runner's knee issue, it's also possible that is the longer leg. And it's not necessarily the longer leg caused those, but it could be preventing them from healing. The same thing happens on the shorter leg. When you have a shorter leg, that leg or ankle is going to come down and increase plantar flexion, and usually out to side and external rotation. This is going to cause problems like Achilles tendonitis. So we're not saying you have to correct those long leg and short legs. However, they could either be causing or be contributing to the lack of healing for those different types of diagnoses. Using this is the same as a different trial of care, putting an orthotic in someone's foot, doing a trial of care as far as using instrument system manipulation. If you can solve enough of those compensations, a lot of times you can get that tissue to heal, and then try pulling it back out just like an orthotic and see how the patient responds.
Fantastic. Hope this information helps you in your clinical practice. Thanks for watching.